Hello, everyone. Welcome. I'm Joel Mall from Virginia Commonwealth University. I have the pleasure of kicking us off for our 20-minute didactic on the impact of boarding on resident education in the ED, educational dead space. You get to watch the wonderful ballet of us passing microphones and clickers and things like that as we go with our group. None of us have any areas of conflict. Sorry, I guess that one changed. It was before. Okay. So our goals and objectives basically are to talk about boarding and overcrowding in the EM, on resident education and potential ways of mitigating or lessening potential impacts. And now I can say nobody has any conflicts. So if we think about what is ED crowding, I think everybody in this room, unless you really are bad with situational awareness, knows exactly what ED crowding is. The multiple factors, including high volumes, flow of patients, throughput, all lead to this bottleneck that becomes ED boarding. But we know that even though we use the term ED boarding, it's really hospital boarding. It's really capacity issues with the hospital, systems level with the hospital or the healthcare system that overall is contributing to what we feel every day as the canaries in the coal mine. If you look at the upward trend of visits to the emergency department and also visits per 1,000 people, this was briefly interrupted by COVID, obviously, but now we're back up again, ahead of pre-COVID levels. So both the number of patients total, but also the number of ED visits per 1,000 people have gone up. At the same time, we've closed hospital beds. So we're getting busier. We don't have as many places to put them because the number of beds and the number of beds per 1,000 people also has gone down. And then these are the wonderful things that people who never set foot in the ED look at us and judge us by. Our boarding times, our length of stays, our door-to-dock time are left without being treated. You see these are all have substantially gone up. And with that, I'll pass to Grace.
So we each all have our own stories of how our patients are impacted by boarding. This actually was looked at in a systematic review in 2018 by Morley and his team, and was found that there are negative impacts on patient care, outcomes, mortality, and errors. What's interesting about the systematic review is actually also the negative impact on the workforce. Increased violence against in the workplace, increased stress, and non-adherence to best practice guidelines. So then the question becomes, what is the impact then on education? So this was first looked at 20 years ago by Heinz and his team in 2005 and found that there were actually no studies looking at the impact of education and boarding. This was expanded upon in 2008 by an SAEM task force, and found that the perceived teaching quality was independent of ED census, clinician educator workload, and RVUs. Since then, in the last 20 years, there have been several studies that have been published looking at this a little bit closer, including different educational outcomes, including patient care opportunities, varied measures of ED crowding. And this is important, as Dr. Mole had mentioned, when we look at hospital boarding versus overcrowding, these are not the same thing. So for instance, you can have a overcrowded ED that is literally bursting at the seams with patients, but not have any actual boarding. In that education scenario, residents may actually benefit in that they have increased breadth of pathophysiology, as well as increased patient care opportunities and procedural opportunities. At the same time, in that same scenario, you may have a negative impact, including just the attendings are a little bit more stretched, right? So there's less one-on-one time available to teach those same residents. Now, what if you have that same situation where your ED is bursting at the seams and then you include boarding? Now, those boarders, which are basically our inpatient admission holds that are waiting in the ED for a bed upstairs, take up those beds and educational opportunities and create an educational dead space. We also looked at studies that looked at the educational effects of operation responses, including a provider and triage, and several studies showed that there were perceived negative impact on the education of residents, including their medical decision making, their development of differential diagnoses, as well as their diagnostic study selection. I did want to briefly just touch on COVID. We know that COVID has dramatically changed the landscape of both the way that we teach medicine as well as the way that our EDs function. We are still feeling the ripple effects of the high attrition rates as well as the burnout from this. Now, in our scoping review, which was actually published today, we looked at these studies and found that there still was a gap in terms of the educational response as well as different strategies that could be implemented to help augment the education environment.
So So yeah, so like the line item summary for what is that evidence that's out there about the educational impact of overcrowding and boarding is that overcrowding and boarding has very clear negative perceptions of educational impact, and boarding has quantifiably negative impacts on resident education. So what strategies are sort of out there to help mitigate those negative impacts? Well, unfortunately, there's just not a whole lot in the literature that offers really specific guidance. This first paper was in 2005 by Atsma, and really sort of talked about varying educational strategies or principles that could be used to help improve the quality of education in an overcrowded or boarded emergency department. And as you can see, these are pretty like high level, generic, and not super specific strategies here. And they actually will apply not just to an overcrowded emergency department, but really any emergency department. Things like tailing your teacher to the learner, agreeing on expectations at the start of the shift, all are things that you should just be doing as part of being a good educator on shift. Um, and then, but it did offer a couple of specific things, such as providing high yield cases and hard copies of additional learning resources to be available, so you have something to teach on shift. Um, Later in 2010, Lynn et al., as part of this CORD consensus recommendation, kind of lumped some of these principles, again, relatively generic, into sort of three different buckets of ways that you could improve the educational environment of the overcrowded emergency department. Strategies that you can work on for the educator, make the teachers working in the emergency department better. Strategies you can work on for the learner, mostly just reframing and resetting some expectations. And then the system, like system level changes that you can make. Obviously, working to try and find ways to have patients have residents see more patients, but also building these teaching files, scheduling teaching rounds, that sort of thing. And honestly, like both of those kind of add up to like the recommendation is to provide a menu of options for you as an educator when you're really working in that overcrowded emergency department, because things may be different on one day than another day. You may need to use a different resource to help improve the education of the residents on one day as opposed to the next. And ultimately, the two goals really that it comes down to is, one, making those clinician educators better teachers, and then giving those clinician educators better resources.
And so, just briefly touching on resources, this is a paper that came out of our institution that sought to kind of provide clinician educators with sort of a plethora of activities and ideas for how to engage their learners in an environment that is boarded and then maybe they're not seeing as many patients. And we kind of lumped these activities into four big groups to include practical and procedural skills, evidence-based clinical practice, medical knowledge, and then some that focus kind of just on workflow or task management. I will briefly touch on a few of these in each category, but obviously there's a QR code there if you want to read the entirety of the paper and kind of explore more ideas. So kind of looking at medical knowledge, one of the examples under this category is like board stocking. So having your resident, when maybe they're not seeing as many patients, but the waiting room is filled up, look at the waiting room and based off of the chief complaint and maybe the ESI and their vitals, decide who they would want to room back or what order they would want to kind of pull patients back. Additionally, in the world of like medical screening exams and patients preemptively getting labs in the waiting room, having them kind of use the limited information that's available to decide like, or to hypothesize, what do you think is going to happen with this patient? This is what they came in with. These are their labs. These are their vitals. Where do you think they're going from here when they actually come back and are seen? Looking under procedural and practical skills, a lot of a few, the papers that are out there about kind of teaching in this environment, a lot of them discuss kind of the interdisciplinary approach. And so not just looking at attendings or residents to be the educators or senior residents to be educators, but also engaging like your nurses and your pharmacists because they have a lot that they can teach as well. And so you may like have one of the nurses show your resident like how a pressure bag works or how to zero an A line, how to put a peripheral IV in without the use of an ultrasound. As those are like skills that will enhance their learning and that not necessarily maybe an attending is going to teach them. From a efficiency kind of workflow standpoint, this is one that I enjoy doing with my interns, but like asking them, how do you get a new patient and you chart biopsy them, and maybe, what is your flow for going through, looking through their past medical history, when their last stress test was, when their last echo was, and actually physically watching them work through that process and then helping them find ways to do that more efficiently. And then lastly, evidence-based clinical practice. And this focuses mainly on there's a lot of clinical decision rules that we use, such as the Wells or the PERC score. And we use them and we explain to people like why we use them and how we use them. But a lot of residents may not know the actual foundational literature behind that. And so printing off one of those papers and kind of discussing the evidence behind why that tool is used the way that it is and kind of the nuances that went into creating it. Most of these things kind of focus on the ED is very boarded, residents aren't seeing a ton of patients, and so this is how you're going to enhance their clinical environment when maybe they aren't getting as much hands-on. Obviously, I think all of our goal is to improve operational efficiency and find ways to get residents more touches of actual patients, which Dr. Thompson will talk about.
So as the medical director, I was tasked with how do we make sure patients are being seen, but also preserve the resident education and the decision-making in that learning process. So this is a swim lane or a visual representation with each role split out of our provider and triage process, and then how patients are funneled into our fast track or urgent care type area. And so when we developed this PIT process, we're trying to balance patient efficiency, seeing patients, but also the resident education. And so we didn't limit the labs that could be ordered from PIT or put any restrictions on that, but we did limit CT scans from PIT. And if someone needed an acute time-sensitive scan, such as for acute stroke, the patient would be taken to the resuscitation bay, and the resident gets to keep that the image decision-making, and gets that learning opportunity. And then at the 4-hour mark, if the patient's still waiting and needs some imaging, we allowed for imaging to be ordered from our triage or lobby area. And this helped kind of with our high boarding or extreme boarding process, which I'll talk about, and allowed the patients to be reassessed while they were waiting. And so our extreme boarding really focuses on reassessing the patients that have already been screened through a medical screening process. And this preserves or allows for the learner with an educational opportunity, because they have to reassess those patients. They can then determine the disposition. They can determine, does a new diagnostic test or an additional diagnostic test need to be ordered? They can just reassess patients, see if anything's changed. And if something has changed, they can increase that acuity. And so still preserving that educational opportunity. The biggest pro to this is that educational opportunity is there, and the more patients you see, the more you get to learn. The biggest con with this is the resident and the faculty they're working with had to be motivated and aware of the situation and actually go out and do that. And so then we'll open to questions.
We're your question people.
Yeah, open-ended questions that you all may have in terms of this is obviously a common experience that we all have. I think that every academic institution is dealing with severe boarding and overcrowding, and is concerned about the educational impacts of it. So happy to entertain any questions or thoughts people have.
Is your PIT model, are you dispositioning patients with the provider and triage, or are they all primarily ultimately being seen by a resident?
We're looking into that to see that kind of how that disrupted the educational flow. The primary process or mode for the PIT process is to see patients and screen them. If there's someone that clearly can be dispositioned right away, say like a suture removal or medication refill, those patients are kind of able to be discharged, but that is not the primary role.
So
Sir.
we have a physician in triage for about 10 hours of the day. Has anyone else thought about putting either an intern out there as a learning experience with the attending, or even a senior level resident as the PIT provider? I mean,
There,
technically an MSc, but it gives them that decision-making opportunity.
Yeah, in our review of the literature, there were no papers that described the role of a resident in that model. There were 4 papers that looked at provider and triage models, and all of them were essentially an attending physician in triage, or there were some that may have had residents as part of it, but it wasn't really well described. And so that's a little bit of a gap in the literature right now. I know personally, we locally would have concerns about I think the biggest question is like, how do you supervise in that environment? Like, I mean, an intern out there that was having a directly observed H&P, and then gets feedback on how they conducted that. I think that can be a good educational opportunity. But certainly, if you can't provide that level of supervision, then that's probably not a good educational opportunity for that person. So. Sir.
Can you walk through a little bit as you reviewed the literature what the like what measurable impact on resident education boarding actually has?
Sure.
I mean, this is the environment we work in. They're going to work in it. Sure, a little less patience here and there, but
yeah. The specific literature is a little bit fraught with some definitional problems. One being, the plenary this morning talked about ED bed capacity as sort of a correlate to left without being seen. And actually, that's probably a good reflection of what your total boarding volume is in your emergency department. But they use varying definitions of overcrowding or boarding and that sort of thing. There were a couple of papers that looked specifically at boarding and found that as you increase your level of boarding and as your NEDOX increases, residents are able to get fewer ultrasounds on ultrasound scanning shifts and not meet the educational requirements that were set out for those. And they also see fewer patients per shift in a separate paper that had looked at that. It was actually done at Dr. Mole and Dr. Hickham's institution. So, yeah. Other papers that have looked at overcrowding are also a little bit fraught with a look at overcrowding that's not quite as severe. There's one paper out of Texas that looked at not crowded, crowded, and overcrowded states, and basically found that the volumes were pretty consistent in terms of patients seen per hour. But the problem is that their not crowded was like a NEDOX less than 100. Their crowded was NEDOX 100 to 140. Their overcrowded was like greater than 140. Whereas that's actually not that bad for most places. We're usually rolling around like 160, 180 a lot of days, and when it's real bad, it's in the 200s. So they didn't sample enough of the severely overcrowded states to take a look at that, I think.
sorry, Paul.
No, it's fine.
Do you at your institutions, and I don't speak for mine, but do you feel like the boarding has impacted your education?
Yeah, I mean, I think that we have concerns that it does, but we've actually, as most recently, had a lot of variability, and we've had some challenges, or not challenges. I would say we've had some confounding factors recently because we opened a new emergency department at our particular institution. But we try to pay attention to the volume of patients seen per year, and we are having to relatively routinely adjust how we do our bed assignments because we do things on a geographic basis to make sure that our second years are seeing more patients than the first years and that sort of progression. So you're being challenged in the appropriate way at the appropriate time. Sir.
Did y'all come across anything about bringing residents in to help kind of understand boarding, troubleshoot boarding? Because it seems like it's something that we're going to experience in the hospitals that we work at, and the more we understand it, the more we can have a voice in trying to help kind of troubleshoot it. Probably the better it will set us up for success, because it is a very real problem.
100%. I'll let Rob take that because he has some experience.
Yeah, I mean, as far as bringing in residents, I have operations electives where I work one-on-one with the residents and kind of give exposure to those residents to kind of see what my life's like. I think the tough part is kind of trying to frame our residents and even our faculty that this isn't an ED problem that we're going to solve. This is a health system. This is a U.S. health system. It's an individual health system. It's a hospital issue, and trying to find ways that get exposure to how that's being combated or how that's being looked at, and where are the barriers, when it comes to the compensation, the revenue generation, and why that leads to some of the boarding issues.
How much interaction do your institutions have with the structured interaction with the inpatient team? This is what you need to do to discharge under your plan, and that transition to that level of education in a different sphere, but nevertheless they're still physically there.
You're talking about dealing with the boarded patients in specific?
Yeah, hospital medicine.
Sure.
When you get echo and you just
Yeah.
if they're okay, they're dischargeable or,
Right.
et cetera. But,
Yeah.
just
We in our institution, our boarders are cared for by the hospital medicine teams and not the ED team. There's definitely a lot of value in those sorts of lessons because if you, as an ED provider, know what the next 2 or 3 steps are for the patient, then you can provide, I think, a lot better care for the patients you see in the emergency department. It also makes your admitting conversations with the hospitalist like a lot easier too. So we don't have a lot of that structured interaction there, but that is a way. I mean, like the kind of title of the talk, this educational dead space. This is a concern: is that those boarded patients are taking up what would be educational space for emergency department patients. But anything like
I can add one more thing on top of that as well. So at our institution, we have a somewhat of similar model. At a certain point, patients will be taken over by the hospitalist, but there's only so many patients that get covered into that group, and we still actually manage them acutely. So it's a co-managed where all the inpatient stuff is on internal medicine, all the acute stuff they decompensate. ED runs over it. However, of the ones that are not taken over by that, one of the things we started doing at sign out is we reassess and we say, hey, does this patient actually need to be admitted? And I think that piece, that cognitive switch of, hey, does this patient actually need to be admitted, has some downstream implications. Because how often you get a sign out from someone and we carry the plan forward and the hospitalist later calls you like, hey, does that patient actually need everything? They got everything done in the ED. And we're so used to carrying plans forward that it actually has shifted our cognitive mindset in ourselves and our residents to look at the sign outs and say, do we actually still need now 6 to 8 hours later to keep following these plans? Because actually everything's done and the patient feels better and they're ready to go home. So I do think there was a little bit of positive that came out of that in forcing us to potentially disposition people that are admitted from the ED when we've done everything we need to do.
Thanks, everybody. We'll stop here with questions and for deference to the next group, but happy to answer anything later.